A very good evening and welcome to St. Felix Parish here at Bankstown for the second installment of our 3-week series discussing euthanasia, dying and the dignity of the human person. My name's Father Ronnie Marie. I'm the assistant priest here at Bankstown. It's my great pleasure to welcome you here on behalf of the young adults of the parish who have put a lot of work in to put these 3 weeks of talks together. I won't introduce the panelists. Monica is going to do that. Monica Duma works for the Archdiocese of Sydney. She'll be our moderator for this evening and lead our panelists in discussion and a bit of Q&A after that. So I'll begin with a prayer and then I'll hand over to Monica. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Heavenly Father, the beauty and dignity of human life was the crowning of your creation. You further ennobled that life when your Son became one with us in his incarnation. Help us to realize the sacredness of human life and to respect it from the moment of conception until the last moment of death. Give us courage to speak the truth with love and with conviction in the defense of life. Help us to extend the gentle hand of mercy and forgiveness to those who do not reverence your gift of life. To all, grant pardon for the times we have failed to be grateful for your precious gift of life or to respect it in others. We ask this in Jesus' name. Amen. Saint Joseph, patron of a happy death, pray for us. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Thanks, Bob.
Thank you, everyone. I echo Father Ronnie's welcome and the gratitude for all of you coming here this evening. A little bit of housekeeping to start off with. For those looking for seats, like legitimately every seat in the front row is empty. So if anyone wants to move up the front, please do so. The toilets are around the corner to my right here, to your left, for those who don't know where they are. There are masks available at the door for anyone who doesn't have a mask, given that COVID safety requires us to have masks this evening. And that's about it. Before introducing our panel, I will say that I'm not going to mention where any of them work. They're here in their personal capacity and not representing the hospitals or other facilities that they work at. So I'll give you a little bit of their background when I'm introducing them, but it's not some glaring omission by not telling you where they work. It's important for them. So, okay, I'll begin. To the very left of the panel is Dr. Shabal Bajani. Dr. Shabal Bajani is a specialist physician in palliative care and currently manages inpatient palliative care unit somewhere in Western Sydney. He works at a number of hospitals and also visits various communities in regional New South Wales, conducting home visits to provide palliative care when needed. He finished his bachelor's degree in pharmacy in 2007 and went on to complete a postgraduate degree in medicine in 2011 at the University of Sydney and has worked in a number of hospitals around New South Wales. He's got a passion in advocating and serving the vulnerable, in particular those who are suffering from terminal illness. He's also got a particular interest in pioneering advanced symptom management strategies that he'll tell us hopefully a little bit about tonight, and participates in medical education and research. He wants you to know, though, that his primary vocation is being a husband and father, and he's a Maronite, like all the good ones, and serves in the choirs there when he's allowed to sing, and sits on the board for Maronite Care. Next to him, we have Sister Cecilia from the Little Sisters of the Poor. And Sister Cecilia has been a sister for almost 50 years now, serving under the mission of the Little Sisters of the Poor, which is to offer the neediest elderly of every race and religion a home where they will be welcomed as Christ, cared for as family, and accompanied with dignity until God calls them to himself. So that's the mission of the Little Sisters of the Poor, and she'll share with us tonight a little bit about how that mission plays out in caring for the most vulnerable. Then next to her we have McHugh, who is a registered nurse working in a hospital here in Sydney. Oh, that just got really loud. He started in the operating theatre and then moved to acute geriatrics, where he became experienced in geriatric medicine and end-of-life care on a more intense basis. He's now working in cardiac medicine, but has gained experience in multiple medical and surgical areas and has a special connection to the end-of-life care environment. He's married to Dr. Kate Crowley, who could unfortunately not join us this evening, but she's the head of the Catholic Medical Association and has dragooned Michael onto the organising committee. And then finally we have Dr. Lynn Lim, who is also a palliative care physician here in Sydney and works at a number of hospitals. Please make our panel welcome. So just a little bit about the structure of tonight. What we're going to do is we're going to start off with some introductory comments from our panellists, and then when they're done with those, I'm going to quiz them a little bit on the panel before opening up to you all for some Q&A from the floor. Thank you very much. So first, I think Dr. Lynn, are you up? You can speak from there, or you can speak from the lectern, whichever you prefer.
So what is palliative care? I think most people think palliative care means that's it, it's the end, it's down that end. It's a scary word. When we meet patients, many of them find it quite confronting. Palliative care, you've come to see me, this is bad news, Dr. Doom and Gloom is here. Very, very, very sad, very depressing. But our work is a lot more than that. Our work is not about just death and dying. First of all, the proper definition of palliative care, our patients are patients with a progressive, life-limiting illness. So it doesn't mean they're down on the last day or the last weeks of death. Our patients do have very chronic, debilitating, severe illnesses that they eventually, yes, will, take their lives, but our goal is quality of life, to, support them, support their families. Sorry?
A little question now.
Oh, sorry, okay, yeah, sounds a bit loud. Support their families, support them, and at the end of the day, what's really important for them? What's important for their families? A lot of people in their quest to be cured of cancer, to be cured of this disease, they lose perspective. They forget that at the end of their life, they are not defined by their disease. It's them, their family, the people, their roles in life, who they are. That's actually what's the most important thing. It's not about, there's a lot of things, fight cancer, fight cancer. Yes, I agree, fight cancer. But what about spending time with your family? What about doing the project that you never got to finish? What about doing all these things that you really wanted to do? What about leaving a legacy for your family? How would your family remember you? And making memories. And I think that's what I think is most important, and I think that's what inspires me. So just because patients have to meet us doesn't mean that's it. There's a lot of things we can do, and we are a multidisciplinary service. It's not just doctors. There's doctors, nurses, allied health, social worker, counselors. So we look at people from lots of different angles, lots of different dimensions. We want to provide holistic care to support them, their whole life, and their families, and who they are. And that's what I think is really important. There are some misconceptions about palliative care as well. People think, palliative care is that euthanasia. Are you stopping treatment? Are you passively killing people? And that's not the case. Our patients clearly are on a path to eventually pass away, but what we want to do is do what's in their best interest. So some treatments in medicine get to a point they really are futile. And first of all, the law and the church agrees that we should not be going for treatments that's extraordinary, that's unrealistic, that's going to put people and compromise them, where at the end, they are put at more risk than benefit. So if a treatment's in the end going to make them suffer and unlikely to rescue them, then there is no obligation to put patients through all this invasive, cruel treatment, where at the end of the day, the goal is their quality of life, their symptoms, and what really matters to them. And that's a lot of what we do. So that's one of the misconceptions. And this also falls along the lines of withdrawal of treatment. Some people are, let's say, in intensive care, on ventilators, and you get to a point it's not working anymore. They're not there, they're not connecting with family. This treatment's not working. We shouldn't be pushing people beyond what we can really help them. At the end of the day, it's their comfort, it's being at peace, focusing on spirituality and things that are really meaningful for them. So just some of the little misconceptions here with palliative care. I think that's pretty much my introduction. Okay.
So I'm going to, I guess, go along with that and say, how does it look like at the interface when you do meet palliative care for the first time? And that can be in a number of interfaces. So a lot of our work is, for example, somebody gets admitted into hospital under another team, let's say under the cancer team or the oncology team, and they need help with symptoms or they are dying. So we will be consulted, and sometimes that is the first time patients and families meet us, when they're unwell in hospital. But that is not the only time, that is not the only way to meet palliative care. We do go out to people's homes in the community, and often our nurses actually are the first people to meet them as a bit of a gentle meeting, talk about what's going on, get to know them. And another way is just like in seeing any other medical specialist, which is being referred to a clinic. And there are clinics running all over Sydney that both me and Lynn work at as well. So I think it's not as scary as it seems. I see many people in clinic that walk in and they're frightened, and I just tell them, I'm human. I might throw one or two jokes because I'm a bit of a comedian. Well, I like to think so. And really just break the ice and just tell them, I'm not here to hurt you, I'm not here to kill you, I'm not here to stop anything that you're interested in. What we're here to do is just to try and make life better. So let's have a chat. And often my first interaction with a patient and their family is about an hour. So whereas you might see another medical specialist for 15 minutes, they go through that particular issue. Well, we don't look after an organ, we look after the entire person and their immediate circle, or what's important to them. And that takes some time. And often one visit's not enough. I'll have to get them back in within a couple of weeks or whenever I can, and then we go on to next thing. So the key there is, and this is I think we harp on a lot about, is early referrals. So we want to see patients earlier in their journey, in their terminal illness, rather than in the last few days or the last few weeks. We can do so much more for somebody in the last 6 or 12 months of their life than we can do in the last day. So I think that's what I want to say, is that we are like any other medical specialty, we are like any other nursing specialty. We're not to be afraid of, and often what we want to do in the beginning is just have a chat and just talk about what's important to you, what we're all about, and how we can help. That's sort of the first part. The second part that I want to talk about is really the mystery of suffering. And I think Sister will probably touch on this a lot better than me. But we see a lot of suffering in our work. And people often, particularly in the political sphere, they talk about pain, 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 pain. To be honest with you, physical pain can be really difficult to treat. But often that's the tip of the iceberg. The issue, the real stuff that's underneath, is the other types of suffering, the other types of pain. And they include social, psychological, spiritual and emotional pain. And particularly towards end of life or at end of life, all these things that people have swept under the carpet or really suppressed come to the fore. You might get sort of, dysfunctional families coming out of nowhere, or someone's distressed about something that's happened in the past, or they've been traumatized, etc. All that comes to the fore, and Lynn can testify to this, that as medical specialists, we're not particularly trained in psychology, etc., but we learn it vicariously, to be honest with you. We actually become quasi-psychologists, quasi-counselors, and friends, to be honest with you. That's what it takes. So very important that suffering, and particularly in the Western world, and I was just speaking to Sister about this, and this is one particular quote that I love from St. Teresa of Calcutta, is the greatest suffering that's happening in the Western world is not poverty and hunger and all the really bad things that she saw in Calcutta and in India. In the Western world, it's actually loneliness. She mentioned that, and that's what is killing people. And often, and we'll talk about euthanasia towards a bit more in this talk, is often the quest for euthanasia is not particularly for pain, it's actually a lot of existential suffering, spiritual and psychological suffering. I think that covers that, yeah. And I'll pass it on.
I think I've got the podium this one. Okay. I've seen many good deaths. I've seen very supportive and kind families who visit their loved one, mum or dad, on a regular basis. I would always see my role as to make sure the patient was comfortable, and I would be asking the family if I can get them anything and invite them to grab a coffee on the ward whilst they were there. The families need our support as well. They're often asking, when will it happen? How will we know? What will happen to mum after she dies? Do I need to sign anything? Like all who are walking in uncharted territory, they need a guide. I see my role as someone who can walk with them during one of the hardest times in anyone's life, the loss of someone who is very near and dear. Most of the time, my experience with death has been a positive transition. It is always sad to see someone who is loved leave our presence, but there is often a gratitude for a good person and a good life. A good and happy death is always our goal, but inevitably, a lot of the very human struggle will come out at the bedside. Finally, the rock of the family, the one who was holding it all together, is dying. And now they are slowly gathering at the bedside. Probably the worst example of this was when the family was gathering to visit mum, and the long-standing bitterness and unforgiveness and accusations suddenly had free rein. Soon, family members were involved in a wild brawl bedside. Security guards and nurses were assaulted when they tried to intervene. The police riot squad was actually called, and a number of arrests were made. Some of you may have heard about that one on the news. At another time, I remember the daughter who came in to see my patient. She marched in, reorganised the room, gave her mum some orders, and then proceeded to walk out again. My patient sat in the bed, staring blankly, saying, "I wish I was dead." I nursed a man whom I was told was part of a very well-to-do family. I had never seen any visitors with him until one day I met the people who introduced themselves as his next-door neighbours. They expressed their shock that the patient had received no visitors from the family. It was rumoured amongst the staff that this man was hated by certain members of his family. Something had happened many years ago. There was no forgiveness, and so this man was dying alone. The sad story often continues beyond the hospital. A friend of mine is a funeral director. He tells the story of families arguing about the will as the body is being lowered into the grave. He told me that this happens more than you think. Families can be the greatest of support in someone's life, but unfortunately, too often many become a source of misery. Our lives are not lived in a vacuum. We are a biopsychosocial spiritual being. We live on many levels, and often within a communal context. We are social animals. We find that we need each other. There are things we couldn't do if it wasn't for the presence of others. This is why the lockdowns have been so hard on people. The patient's call for euthanasia comes from a context. It doesn't come in isolation. When someone expresses the wish for death, we are drawn to ask where that call is coming from and what are the influences that have led to that request. From the few stories that I've just told you, you can see that some of people around us can be a real source of conflict and misery. For a person who has become more dependent upon the help of others, they find themselves feeling undervalued and even an increasing burden upon the people around them. Whereas the dying person with loving and supportive families and friends, the path to their last day is certainly a different story. In recent years, we have seen the gradual decline of faith and the increase of voices who publicly declare their opposition to any religious sentiment at all. The arrival of Dr. Richard Dawkins, Sam Harris, and Christopher Hitchens onto the public stage has certainly eroded any positive conception of the existence of God or any ultimate meaning in life. Science, they say, is their proof of this. The behaviour of some members of our own Christian churches has eroded any positive view that Christianity has been any kind of help in preventing evil amongst the innocent. The removal of any counter-narrative to the secular worldview from the public space has forced the believer underground, and in some cases afraid to speak of faith at work or anyone else, or anywhere else for that matter. The godless libertine has come out of the closet, and the Christian has been thrown in to take their place. We sense it, don't we? There is a greater sense of nihilism, meaninglessness today than in former times. Many of us have lost our sense of ultimate purpose or even immediate purpose. Sure, many people are quite functional. Many have things that they're interested in. They have goals surrounding career and family, but in the end, they have not seemed to explore whether there is anything beyond their immediate concerns. You and I have met many people like this. I meet them all the time on the ward, and they are often the ones who are deeply unsettled when a difficult diagnosis comes. All of a sudden, they are asked to factor in something that has not been considered by their worldview. I want to share with you an important quote from Viktor Frankl, a Jewish psychiatrist who went to Auschwitz during the Second World War. The miracle of surviving this situation gave Dr. Frankl much to think about and significantly changed the way he approached psychiatry in the years following. Viktor Frankl wrote, "If we present a man with a concept of man which is not true, we may well corrupt him. When we present man as an automaton of reflexes, as a mind machine, as a bundle of instincts, as a pawn of drives and reactions, as a mere product of instinct, hereditary and environment, we feed the nihilism to which modern man is in any case prone." I became acquainted with the last stage of that corruption in my second concentration camp, Auschwitz. The gas chambers of Auschwitz were the ultimate consequence of the theory that man is nothing but the product of hereditary and environment, or as the Nazis like to say, of blood and soil. I am absolutely convinced that the gas chambers of Auschwitz, Treblinka and Majdanek were ultimately prepared not in some ministry or other in Berlin, but rather at the desks and lecture halls of nihilistic scientists and philosophers. A few years ago, I attended a debate about euthanasia between Archbishop Anthony Fisher and Dr. Peter Singer, the utilitarian ethicist who holds the chair of ethics at Princeton University in the United States. During the debate, Peter Singer stated, "We really need to get away from this idea of the sacredness of human life." I didn't know about anyone else in the room that evening, but my jaw was on the ground, and I felt like the gates of hell had just opened out underneath me. Viktor Frankl's words were echoing in my head. I had just heard in the lecture hall the words of a nihilistic philosopher, the same words that built the death camps in World War II. What shocked me was afterwards, the amount of people lining up to get Peter Singer to sign a copy of his book was far bigger than the line of people waiting to see Archbishop Fisher. Was it because people would go along with anything so long as they got what they wanted? Or was it because people really believe that there is no ultimate purpose and suffering is thus intolerable because of this? Meaning is intrinsic to the suffering of every person. Study after study has shown that those who see no purpose in their life or suffering are the ones who suffer the most. The studies also show that those who do have a sense of meaning are also those who are more resilient. A deeper sense of meaning and purpose, which comes from the very human ability to ask why, is an anthropological reality that has made people more steadfast in the face of all the joys, sadness, and suffering in life. To simply dismiss the argument of the religious in this debate is to dismiss what has been proven to make people more functional. The claim that science is on the side of a meaningless universe flies in the face of what science has shown makes people work best. Those who see no meaning to life and its concurrent suffering are the ones we are trying every day to save from suicide. Autonomy is the thing that will get someone to the edge of the cliff, but it is meaning that will talk him down. I'm against euthanasia, and it is clear to me that it is a dysfunctional response to the deepest questions we can ever ask ourselves. I'm against euthanasia because it is evidence of a society that it's lost its soul and only finds satisfaction in self-indulgence, self-gratification, or escape and distraction. I'm against euthanasia because every person, even if they can't see it, has a deeper purpose and a special part to play. I pray for my patients and I encourage them to find a mission or a purpose for their last days because I know they deserve the best. Isn't it ironic? This is the year of St. Joseph. Yes, he is the patron of the church, but he is also the saint we pray to for a happy death. Yet, here we are talking about euthanasia. Why? I submit to you that it's because many of us have been carried along by the stream of our culture and have lost our sense of purpose. It is only those who know their life is meaningful who can say, "Pray for my happy death." Thank you.
Thank you, Michael. Okay, now I'm going to spend some time quizzing the panel before I hand over to you and let you do the same, so I get to have the fun first. And first of all, Sister Cecilia, I'm going to start with you. Would you be able to share with us a little bit about the mission of the sisters, particularly in terms of accompanying the dying in their last days?
I think I'd better stand behind.
You want to stand up here?
It's a good body.
Exactly. The Little Sisters of the Poor take in the elderly, so it's quite a different sort of scenario to what the team has presented. Our elderly tend to be from 65 up to 100 and, at the moment, 8. Yeah. And we can have numerous 100-year-olds. Oh, sorry, I better have a drink of water.
Sure, I'll get it.
Thank you so much. Our main thrust is to provide a home for the elderly. As Little Sisters of the Poor, our readiness to face the possibility of legislated assisted dying consists in bearing witness to the respect of life for every person, made in the image and likeness of God, and in supporting those who carry a burden which is seemingly too heavy and could lead to the thought that it is better to finish all. Can you all hear? Yeah? Okay. So what do? We accompany. Have you ever thought about what that word means? We break it up. Com means together. Pan, I believe, is from Italian or Latin maybe, meaning bread. We share together our bread. For us, we share our home. It is the residents' home. And we share their bread. We share the bread with them. We walk this journey of life with them. Our world will say, old people, what products can they do? What can they produce? What can they, give the world today? They are just perhaps sucking up energy and need. But no, they've lived their lives. And I often think as I go around the residents' rooms, I only see a shell of what that person was. A lot of the residents we have no family, or perhaps they're from dysfunctional families. They don't have many visitors. But those who do come, they're very warm, loving families. And so we become for our residents their family. And that for us is so important. It gives them a sense of dignity that somebody wants them, that there's still something in their life that's important. And it takes courage to sit with them and find out what that is. We accompany, which is so important. We are committed to giving skilled quality care to the elderly. You have to excuse me, I'm reading my notes as well. In our homes where a person is accompanied, we rarely ever hear the request to end it all. One will sometimes hear, I'm afraid of dying in pain. And who isn't afraid of pain? And really, who's not afraid of death? With skilled palliative care, modern drugs, pain can be controlled and comfort given. And I think, as Charbel said from Mother Teresa, the greatest pain I think anyone can suffer is loneliness, feeling isolated, that no one wants them, that they don't have meaning in their life anymore. Each member of our staff, we have a big staff, we're only a limited number of sisters. We really need a lot more if there's anybody interested. Each member of our staff, no matter what their particular role is, has an important role within the home of the residents. And they get to know them and love them very much. So coming to the time of anyone dying, we actually, the sisters, we vie with one another to spend the night with them. We usually divide the night into two, so that they know that they're never, ever, ever going to be alone. And that also, I think, rubs off on the staff. They actually, too, sometimes they've come when it's been a long period of looking. We call it the watching of the dying. Sometimes they've said, "Sister, go to bed, you're tired, it's a week, and we'll be in your place." We really give that up. We don't give that place up. It's a very important position to be. And the residents know that they're never going to be left alone. So it's really important. We value our tradition of providing a constant prayerful presence to those who have entered the dying process. We invite all those who collaborate with us, our chaplain, our staff, that's the cleaners, the kitchen people. We've got associate people who assist us as well, volunteers, families of the residents, to participate in the sacred moment when, yes, they leave. And usually the room becomes, if you like, almost the heart of the home. The residents around them come and visit. It's not something we close the door to hide. St. John Paul II once wrote, "The temptation to give up in utter desperation is above all a request for companionship, sympathy and support in a time of trial. It's a plea for help to keep on hoping when all human hopes fail." Even our foundress, she never used the term, Jan Dugan's her name, palliative care, but she had its spirit and its intuition. She used all the means available to her to bring comfort and pain relief. She surrounded the elderly with thoughtful attentions, visiting them and increasing contact with their families. And often, sometimes we've actually found families of residents who said they'd never seen their families for a long time. Following her footsteps, we have done this for over 150 years. We are throughout the world, many homes throughout the world. We have many nationalities, even within the home here in Sydney. The serenity of old age in our experiences increases by having the security of being loved and cared for until death. Old age then becomes like that beautiful sunset, a life slowly ebbing away. The well-known phrase of Dame Cecily Saunders, who I think was the foundress of Palliative Care, "You matter until the last moment of your life, and we will do all we can, not only to help you die peacefully, but to help you to live until you die." And that's also something I think that we find important. When getting to know a person, you know the things they like and the way they like to do things, or the way they like to be snuggled in the bed, or whatever it is. It is important. We strive to provide the means where residents can live and not just exist. Life is much more than providing a roof over one's head and something to eat.
Thank you for that, Sister. I'm going to start quizzing our palliative care doctors a little bit about some of, I guess, the allegations that get thrown up against palliative care by those who advocate for euthanasia. And so I'll start with the big one. Palliative care can't fix all pain, and that there will be some people who will die in intolerable, unbearable suffering and unbearable pain at the end of their death. Can you just maybe talk a little bit about that accusation as it's thrown at palliative care, and also what you can do for somebody for whom some of the palliative care doesn't work?
Maybe I'll share this with Charbel then. First of all, this is very, very rare. The vast majority, there's lots of things we can do for them. Like I mentioned before, it's a multidisciplinary service. So we look at all the different ways, all the different factors that's contributing to someone's suffering. I mean, the most prominent one always is pain, trouble with breathing, and with the right combination of drugs, looking at what the things that we can still treat and we can still fix, often we do manage to relieve people's pain. So there's often misconception, fear of dying in pain, but there's lots of medicines we got out there, there's lots of research going on, we've got lots of medicines we can use, and including procedures and radiotherapy. There are things out there we can do to relieve pain. And as Shabal mentioned, pain is just not about physical pain. There's a lot of psychological pain, depression, anxiety, the loss of self-identity. A lot of people, this is who they are. Let's say if they're a builder, I'm a strong man, I'm a tough guy, family provider. Next thing you know, I'm disabled, I'm stuck in bed, I can't play with my kids, I can't do this, I can't do that. And we can work on that. What other things we can do? How can we still help you find meaning despite your suffering and disability? And I think as both Monica and Charbel mentioned, and also Michael mentioned, is finding meaning. And if we can find meaning, there's some things we will have to let go, but there are things that if we can find meaning in other things and focus on other things, that actually helps with managing this emotional and psychological suffering. Also, like Sister mentioned, the loneliness for someone being there with them, and also helping them with also the basic things that our service can provide. Just, equipment at home, services, having that extra help. I can give an example. I've got a story. I've had a man with basically motor neuron disease. That's the, thing within the ice bucket challenge thing. This poor guy lived alone by himself. Real nice guy. So he first started off with head and neck disease, couldn't swallow. And then when I met him, he said, I can't move my arms anymore. I can't move my legs anymore. That tells me his disease has gone worse. He lives alone, stubbornly independent. I still want to live by myself and do all this by myself. That's all right. And also, we said, can we get services to help you? No. Can we do this? No. No. And he made up his mind. He said, all right, he made up his mind. He's been on the dark web. I'm going to buy some Nembutal. I'm going to watch Joe Biden's inauguration, and after that, I will take the Nembutal and die. Made up, I think it was the 26th of January or something. He made up his mind, got a date, told us that. We all freaked out. This man's going to be at home and kill himself and has refused help. So we all got in, our community nurses got in, checked in on him, spoke to him, counseled him. We even got psychiatry coming to his house, talking to him. And despite all the resistance, suddenly he kind of got used to us and he opened up and he was, okay, the nurses can come in. All right, I'll accept this service. I'll accept that, yes, I can't do these things for myself. It's okay for people to help me. It's fine. And this is really good. People are helping me. We actually even got a nurse in his house 24 hours a day. And so there was a nurse day and night. And one day, he just passed away in his sleep. He went to sleep, and he died on the day of Joe Biden's inauguration. And he missed it. Unfortunately, he died in the morning. He missed it. But he died in his sleep. He went to bed, and he fell asleep. And the Nembutal had not arrived. It's from Mexico, and it had not arrived. I think I've done enough talking. Charbel, do you want to?
Wow. I'm glad I wasn't part of that. I think, that's great insight, and I have very similar experiences. But the fear is still there that, okay, well, proponents of physician-assisted suicide euthanasia would say, well, be it 0.01% that will have that terrible, terrible end-of-life pain or suffering, and you've tried all the drugs, you've tried everything, and the person's suffering, and suffering badly. And to be honest with you, we do suffer with the patients as well. The nurses and the doctors don't think it's easy going home and switching off either, and the family, and there is a lot of distress. And so they'll say, well, just give them a big dose of something and just let them go. It's actually more humane. We treat dogs better than this. We treat horses better than this, etc., etc. I think just from a purely medical answer, it depends on how close they are to end of life. If they are quite close, within a couple of days or weeks, it is ethical and it is not euthanasia to actually, what we say, sedate somebody, so palliatively sedate somebody. And that is not hastening death, that is actually reducing their level of consciousness. And it doesn't mean we have to put them in a coma, as in a complete coma, but reduce their level of consciousness to a point where they are unaware of their suffering and their physical and their existential agitation and distress is controlled. So if I cannot control the pain or whatever symptom, shortness of breath, etc., can we control the distress that's caused by the pain? And in the vast majority, if not all the cases, that can be done. I think I can probably think of one case that I had a lot of trouble with, and that was an issue of resource, to be honest. So the more resourced we are, the better technology we have and medical science we have, the more that we can do. So that's, I guess, if someone is quite close to death, we can sedate them. But if they are months and months and months away and they are suffering, there are, above and beyond the drugs, which are excellent these days, we have a vast array of drugs, and we are reinventing, I guess, new uses for old drugs as well, continuously, and with a lot of, I think, avid research as well. But on top of that, we have now increased procedures, and I just recently sent one of my patients over to Lynn's hospital. I'm not sure if you're aware of this patient, but one of your colleagues helped out, and she actually got a neurosurgical procedure on her spine to get rid of her pain, because I had tried absolutely everything under the sun, and I consulted widely, and she wasn't that close to death. She probably had another 3 or 6 months left to live. And she was a young woman, and she had children, and so she really needed to be as functional as possible, and that got rid of her pain. However, it didn't get rid of her misery. Why? Because remember that iceberg that I said? So pain was only on the top. There was a lot of rubbish underneath in terms of her life story and a lot of, I guess, unsorted business underneath and the baggage. But once we got rid of that big sort of distractor, we were able to then address one thing after the other, one thing after the other. And sort of a happy ending to the story, we just sent her to Queensland on Tuesday, which was, thank God the borders were open, but which was her and her partner's and her children and her family's wish, is that she needed to return to Queensland. And it was a massive effort, but because we had done that procedure, which perhaps in poorer countries or in less resourced countries was not going to be an option. So I'm very blessed to work in a place like Sydney. We do have those options. And if we just continuously killed off these people that were just suffering, kill, suffering, kill, suffering, kill, then we ruin the journey. And I won't take long, but what I tell most of my patients is whether they're suffering or not, we are in the trenches with you. We are suffering with you. And Sister was sort of talked about the etymology of the word accompany. I'd like to talk about the etymology of the word compassion. We all talk about compassion, even in the secular world. Compassion, what does it actually mean? Well, com means with, and passio means suffer, to suffer with. So rather than abandoning them, suffer with them. Go in there. It's okay, I shed a tear or two, and they're actually genuine. Or I'm actually really sad for them, what they're going on. And often, more often than what you think, that can be enough to know that you're there, rain, hail, or shine, to look after them.
Talking about compassion, yesterday on the steps of Parliament House in South Australia, there was a group protesting in favour of euthanasia because they were debating the laws last night in the South Australian Upper House. And the group there were holding up, the letters to spell compassion. And so I think there's a real, I'm glad you said that, because I think there's a real misunderstanding about what compassion actually is. and euthanasia is essentially the opposite of that. But speaking about South Australia, one of the amendments that was suggested last night and was voted down in the Parliament was that institutions should have the right to opt out of euthanasia. So the individual medical professional has the right to say that they won't be involved in euthanasia. But the proposed South Australian law will not allow an entire institution to say, you can be sure that euthanasia will not happen on our premises. Sister, I might ask you, what do you think the difference is for a patient or a resident going in to an environment where they know that euthanasia won't happen versus one where it could be happening and facilitated by the people who are looking after them?
That's a difficult one, isn't it? I think, to be honest, for us, from the moment a person actually comes to the home, we talk to them that we do not practice euthanasia. And in their admission information, they actually sign on the back of the document that they understand that we don't practice euthanasia. I think it gives them a sense that, hey, we're not going to hurt them in any way. We don't want to hurt them. We want to walk the journey with them and, I think, understand their pain, share with them their pain, but not to terminate. I'm hoping that that would give them total peace, and also for all the residents within the home, they know that we will seek to do what we can symptomatically for any problems that present, but we're not just going to hide it underneath the carpet or try and give that magic pill that sort of, lessens them. We do have recourse to the palliative care service. We have to, because, that's not our total profession, if you like. We are caring for the elderly. Palliation is certainly important, but we are not experts in that area, so we always have to make recourse to palliative care people. I'm not sure if I've actually answered the question there.
No, that's great. Michael, I'll flick to you. Have you ever had a request for euthanasia from a patient, and how do you deal with requests like that from patients or from families? And I don't know whether Lynn or Shabal want to answer this either. So yeah, how do you deal with requests for, can't you just give me something to make it all go away?
Basically, I listen to them. That's the first thing. And I try to journey with them in some ways. I ask them what's going on, those sort of things. They need to be heard. A lot of the times that's what it's about. It's just want to be heard. And they are getting weary, they're getting tired of all this stuff that's going on with them. So really, I think my intervention, if you want to put it that way, is to listen and ask for more information, journey with them. That's essentially it, really.
Anything to add?
I think empathy helps. I think, like Michael said, they need someone just to listen to what is bothering them, what's driving the request for euthanasia at the end of the day, what's making them feel this way. As I said before, it's more than just symptoms, it's more than pain. It's something else deep inside that's driving this. The loss of identity, disability, the loss of function, the fear. I think fear drives a lot, like you said before, fear. I don't know what the future holds. I don't know what's going to happen to me. I don't know what's going to happen to my family. I just want to get away from this. So we focus on all these things. It's a very multi-dimensional thing we work with. We have to look at all these aspects. Sometimes euthanasia can come from family. Family have requested for euthanasia. I've got another story. Charbel will be your turn to tell stories. I had a man who was dying. This man was unconscious, and he just couldn't seem to die. He was unconscious, dying, but just not dying. And his family were there by his bedside every day and watching him. He was comfortable, eyes shut, like sleeping, He was comfortable, but his family said, this is suffering. I can't look at him like this every day. This is suffering. I can't bear to watch this. And one of it was his daughter, and his daughter actually also had cancer. So her was projection, her fear, what's going to happen to her. She was in remission, but I think there was a lot of that going on. And she basically said to me, can you hasten this up, get this moving quicker. I can't watch this anymore. This is suffering. Can you just make him go quicker? So I tried to work on all the different things. And this story is a little bit more, bit more than science can explain. So this is from my personal experience. And it's more than science and psychology and all the academic things can explain. I said, is he waiting for anyone? Is he waiting for anyone to say goodbye before he goes? And they say, yeah, everyone's in. I said, are you sure? Think again. And they said, well, there's the grandchildren. They've only spoken to him on smart FaceTime. And I said, what's his relationship with the grandchildren? He took them to school every day. And when he got to hospital, they never came in because of COVID. And I said, maybe he might like to see them. So I spoke to the nurse, because we have to be advocates for our patient. I said, this man's dying. I know there's COVID, but can we work around this, get the grandchildren in? Grandchildren came in. Then next day, he died. So, he died. And then I got a thank you card. And the thing I said to them is, great the grandchildren is. What I'm telling you, this advice, is something science cannot explain. A lot of things in life, science cannot explain. This waiting for the grandchildren, science cannot explain. So on the thank you card, they say, thank you to the ward, blah, 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 and thank you to the doctor who said with me, of course. And they said, and they quoted me actually, they say, some things in life cannot be explained. Love cannot be explained by science. Lots of things cannot be explained by science.
I don't think I need to add on to that.
Yeah, I wasn't going to let you. I have one more question, and then I will throw it open to the floor. It's just statistically likely that a number of us will be faced with a diagnosis of a terminal illness, either ourselves or a member of our family or something like that. And so in that shock and all of those things, what advice would you give to a family in terms of practical steps, right? Once I guess the shock of all of that's been taken in, what's the practical steps? What would you like families to know? You said that, Shabal, you said before that early referral is important, but sometimes you don't get to see people until sort of the last few days or the last few weeks. What would you like families to know so that to better prepare themselves and their loved ones for that moment?
This is particularly about families?
Yeah, families or the individual patient themselves.
First of all, if it's early enough in the journey, whether it be cancer or any other terminal, or it doesn't have to be cancer. This is one thing that I really want to mention, is that palliative care was born out of cancer, but it's not just cancer. We do a lot more. But whatever it is, we are there to make decisions with them, and that they should be making decisions based on information. That's really important, not misinformation. So there's a lot of misinformation, particularly on Dr. Google and goodness knows what, and YouTube and Facebook, and I sound like an old person now. No offense to anybody. But it's, so I think that's really important, and we're happy to take on their questions and help them with that decision. And that's actually a new model, or a sort of a more modern model, called a shared decision making, and that's really important. There's no question that's too silly, and there's nothing that cannot be discussed within the confines of the clinic room, for example, or at the bedside. Whatever's on your mind, and I make myself and the team make themselves available to listen. We pull up a chair, we sit down, and we show them, not going anywhere, tell me what's on your mind. And I like to prod and poke as well. It just makes my job fun. So often, and there's a lot of, and look, there are advanced communication skills courses that sort of Lynn and perhaps Mike would know about, that you get the non-verbal cues. If someone's not looking right, if there's a cue or even a verbal cue, something is not feeling right, they're not responding like you would like them to prod and poke. But there are certain ways, certain skills that we can use to prod and poke. In terms of, I think, getting ready, there's no one way. I think what's really important is you communicate your wishes. So make sure that there's a forum to communicate your wishes. Now, and you also have to be very culturally sensitive. Particularly in Sydney, very multicultural society, and different cultures deal with death and dying very differently to, for example, the Western or the sort of the white Anglo-Saxon, or very, very differently. But it doesn't mean it cannot be addressed in any certain way. So I think address wishes and make sure, and I mean, euthanasia proponents are all about autonomy, but often within this whole process, the actual sick persons they're forgotten in the middle, give them the actual platform wherever they have capacity, give them the actual platform to talk and speak their mind, and sort of shush everyone up and say, let them speak, if they're comfortable to do so, but give them that platform. And I think it should centre around what their values are, what their wishes, and make sure that they have a chance to communicate that. And that's what I was talking about. Often I get them back, because it can't often be done on the first time I meet them. Hi, tell me that you're dying. You know, it just doesn't, it's got to flow naturally. And likewise at home, it's got to flow naturally as well. And then you have all the other sort of practical elements of the power of attorney, the will, the enduring guardianship, you know, make your wishes known, what's important. And look, you can Google this is safe to Google, just the New South Wales Advanced Care Directive or Advanced Care Planning. I often print that to patients who are, I think, are well predisposed to this, predisposed to actually receive it well. And it's often just a guide as to how I would see life or how would I value life for myself if I was unable to eat, unable to speak. Would it be unbearable? Would I not care? And it just gives an idea of where the person's at psychologically, and helps communicate that to the family as well.